everyone. Welcome to week 7. As you might have noticed, we have a guest lecturer this week who is helping us cover the research methods in clinical psychology. Brianna Preiser is a fellow PhD student in the clinical psychology program, and I invited her to help with this week's course materials. However, I'm also familiar with that subject, so if you have any questions about the lecture material or the textbook, feel free and reach out to me as well. So I've paired chapter 11 with the chapter on research methods because I think they go together very nicely. Chapter 11 focuses on these two key questions in psychotherapy. Does psychotherapy work, and which type of psychotherapy works best? And it's really helpful to have a background in research methods to understand the ways in which clinical psychologists might conduct research to help answer these questions. So a little bit about the history of this question of does psychotherapy work? So before the 1950s, there was actually very little research being done. So there was very little evidence whether or not psychotherapy worked. Instead, therapists would just write subjective descriptions of their client's progress. And these notes could be, looked at as case studies, as evidence that therapy was working. But it was really all from the therapist's point of view. There weren't any controlled studies being done. Then in 1952, Hans Eysenck, who you might recognize his name, he contributed a lot to psychology and personality psychology as well as clinical psychology. He published a study that concluded that most clients got better without receiving therapy. And as you can imagine, this is a very kind of controversial statement to make. So thinking about the history of where we are in the 1950s, this is when clinical psychology is really growing, and we see a lot more clinics opening up, a lot more training programs to help train up therapists. And on the side here, Hans Eysenck is saying, therapy doesn't even work. So ultimately, his methods were criticized, but the importance of this study is that it really led to thousands of treatment studies. So it kind of riled people up. They got people interested in this question of does therapy work or does it not work? And so the importance of the study is that it really opened the door to much more types of research studies to answer this question. And so in the 1960s and 1970s, we see many treatment studies starting to be published. And then later on, we now are seeing, meta-analyses that are used to combine the results of these many studies. And so these meta-analyses, and by looking at these kind of treatment studies overall, we can now say that psychotherapy is useful. So Hans Eysenck was incorrect. Most clients do find a benefit from psychotherapy. So in thinking about does psychotherapy work, we need to ask the question, who is determining if it works? And so we can turn to the tripartite model developed by Hans Stroop. And he said, we need to consider all three parties of the client, the therapist, and society when we're evaluating if therapy worked. And so if we think about the client, so it makes sense to ask the client if therapy worked. They are the ones who are directly affected by the therapy. However, they can be biased. So a client might be eager to see positive results. They might see things that have changed that really haven't changed. They just have kind of more awareness about it. On the other hand, they might have symptoms that are actually clouding their appraisal of progress. So in depression, a lot of times people just feel really bad and they might not recognize small changes. So just anecdotally, I've had clients where I asked them to rate their mood on a scale from 0 to 10. And some of the clients with depression might be consistently giving me 4 out of 10. So like every day they feel 4 out of 10. They just kind of feel average, kind of flat, not very good. However, me as the therapist can see that they've made changes in their life where they're like socializing more, or they've made progress in their work or school, or they're developing family relationships. And so even if their mood isn't changing yet, I can see progress that they would not necessarily report because they are still experiencing symptoms of depression. And so in this example, I was talking about myself as the therapist. And so a therapist is another party that's included. And they are trained in mental health issues, so it's logical that they would be able to identify and track changes in behaviors and feelings. And they are often involved in the goal setting, so they are an ideal person to kind of be involved in monitoring if treatment is working. But therapists can be biased too. So oftentimes, most of the time, therapists are not seeing their client in their day-to-day life. If you're only seeing the client 1 hour a week, you're not necessarily getting the bigger picture of what's going on for them. There's also the risk that, if a therapist admits that the treatment isn't working, that could reflect poorly on their own skills. And so there might be incentives, whether it's conscious or unconscious, to not, report that a therapy didn't work for a client. Lastly, we have society. And so society can include friends and family, the legal system, the general public, the health insurance companies, basically everyone else except for the client and the therapist. However, as you can imagine, this can be biased too. So a lot of times when society is deeming if a person has benefited from therapy, they're not going to be caring about that person's internal experiences. It's going to be more focused on functional behavior. So with children, it's often, are they now well behaved in school? And that doesn't necessarily get at how the child feels inside or how things are going in other settings. With adults, it might be related to the legal system or their ability to function at work. And that's more about how society is seeing someone's behavior, not necessarily about internal changes. And so, looking at all three of these parties, it's clear that we really need to have a combination of all three in order to really decide if treatment is working. So besides asking the client, the therapist, and society if it worked, how else can we know if psychotherapy is working? And there's a lot of different ways, so I encourage you to comment if you think of any ideas that I haven't suggested here. But a couple of things that people have been exploring. We can look at neurobiological changes that are measured by fMRI or PET scans. However, this is really still in the early research stages. And, back in the 90s and the early 2000s, people really thought neuroscience was going to kind of be this huge paradigm shift in psychology and that it was going to give us all these clinical tools. And it really has not panned out yet. So neuroscience is still really helpful in understanding kind of physiological aspects of the brain. But in terms of actually having clinical utility for clinical psychologists, it is still in the early research stages. So unfortunately, we can't look at that much. We can look at other things such as medical cost offset. So we can just look at outcomes such as the fact that, clients receiving therapy spend fewer days in the hospital and they spend less on medical bills overall. So we can kind of look at this at a really big picture lens. We can say, for the entire state of Hawaii, we can divide up everybody and say, clients who billed for insurance for therapy versus clients who didn't bill insurance for therapy. And then we can look at their medical costs. So in a way, we can look at big picture benefits of therapy that are not focused on specific clients. But I encourage you to comment if you have other ideas aside from these ways of measuring therapy outcomes. Another thing to consider is when to ask about therapy outcome. So time can really influence the results of therapy. If you ask somebody halfway through therapy versus on their last day of therapy versus 1 month out versus a year out versus 10 years out, their response and their ability to connect what has changed to the therapy will likely have changed. And so when doing a research study, it's recommended to include multiple follow-ups. So, it's great that somebody has changed during the course of therapy, that you can measure from the beginning of therapy to when you're going to discharge the client last session. It's great if you can see the progress, the client's reporting progress. But in a research study, it's really helpful to see if those changes last. So it can be really helpful to measure 3 months out is a common window. A year out can be great if the clients will come back and report on their progress. And again, how to measure this outcome. So, we were talking about who determines if therapy worked, but how we're measuring that matters too. So are we just giving them questionnaires to report on symptoms? Are we doing more thorough interviews and asking questions about their progress? Or are we looking at behavior changes? And so these are important questions when you're considering how to measure the outcome of a study. I'm not going to go over these in detail because Brianna went over them in her videos, but it's really important this week to know how efficacy and effectiveness differ from each other. So efficacy refers to how well a therapy works in a lab setting when we have a highly controlled environment. And then effectiveness refers to how well it works in the real world when we don't have that highly controlled environment. And so results of efficacy studies for psychotherapy, they really show us that psychotherapy works and it endures over long periods. It also tells us that psychotherapy is not a panacea. So what this means is it doesn't fix everything. People show improvements, but it doesn't erase problems. It doesn't erase emotional changes. It simply helps improve certain things. And a trend in efficacy studies is to really take this transdiagnostic approach. And so what this means is that we need to find kind of this underlying pathology that causes the specific symptoms and not look at each diagnosis or disorder as a distinct thing. And oftentimes the main target of this transdiagnostic approach is just what's called like a general emotional disorder or a negative affect. So if you think about something like social anxiety versus panic disorder versus an eating disorder versus alcohol use disorder, there is a common underlying element of somebody having a lot of difficulty experiencing and managing this broad level of distress or negative affect. So you could call it anxiety, you could call it negative affect, you could call it mood dysregulation, but it's kind of considered this broad thing that underpins a lot of what we tend to categorize in the DSM can be kind of all lumped together and said to have this common ingredient. And so there is a trend in efficacy studies to really see if psychotherapy can work across DSM diagnostic categories. And what's come from this is there is actually a treatment protocol that's really interesting called the Unified Protocol. And essentially what this means is that it's a treatment manual that has been designed for use across a lot of different people, a lot of different clinical presentations. So you no longer necessarily have to find the protocol to use for eating disorders or for alcohol use disorder or for generalized anxiety disorder. You can use the Unified Protocol for anyone who's experiencing kind of this emotional disorder. So I think this is a really interesting trend in efficacy studies because it takes some elements, it's being studied in a highly controlled lab setting, but it's allowing for a lot more diversity in patients and their clinical problems. When we look at effectiveness studies, these don't happen as much as efficacy studies. They're actually kind of harder to conduct from a research standpoint because you need to have a lot of community engagement. You're measuring how a treatment works in the real world. So you need real therapists or real clinics to be involved. You need patients that you can track, but they're also kind of in the real world. So you're not necessarily having them come into your university and doing therapy in that type of setting. However, the effectiveness studies that have been conducted, they do support the usefulness of psychotherapy in community populations. And they really do tell us that most people do get better with psychotherapy. And so this is a really important finding, again, to contrast against Hans Eisnick's 1952 study that kind of told the world that psychotherapy didn't work. We can now say that, we've looked at efficacy studies, we've looked at effectiveness studies, and we can conclude that psychotherapy does work. And as we would expect, the research tends to show that treatment effectiveness is slightly lower than treatment efficacy. And this is what we would expect because it's the real world. So we have a lot of factors that are out of our control. The psychotherapy probably is not being delivered in a totally standardized way. We might have clients that are skipping appointments or no showing to appointments, who are dropping out early. And so it's really cool that it still shows that even in the real world, psychotherapy works. We can also talk about how culture plays a role in evidence-based practice. So empirical studies are really important for identifying which treatments should be considered evidence-based. So you'll remember that research is an important component of that three-legged stool of evidence-based practice. But we need to ask ourselves, what if the subjects that are in treatment studies differ from clients in the real world? So for example, if they did a study on treatment for depression in New York City, and they recruit only people who've lived in New York City their whole lives, and the study is done in New York City, can we then say that that therapy works for people living like on Maui, for example? And I would say it depends. You know, we need to really look at if culture and environment plays a role in how effective psychotherapy is. So there was one review study that looked at a lot of efficacy studies between 1986 and 2006. So this grouped together a bunch of different studies. So this included over 10,000 different clients. And they found that no studies were actually looking at how the efficacy of therapy differed across ethnic or racial groups. And other studies have found that people are also not looking at differences across LGBTQ groups or gender differences. And so this is an area that is like still a very big gap area. Things are improving. You know, in recent years, there's a lot of focus on multiculturalism, as we've talked about. But this really highlights the importance of effectiveness studies to be conducted across a bunch of different areas. So if the efficacy study occurs in a lab, the effectiveness study should then aim to be conducted in a lot of different settings to see if it works in the real world. But the way that the real world is defined needs to be across different cultures and settings. This is somewhat related to this idea of culturally adapted treatments. So sometimes therapy manuals are designed for a very particular cultural group. So they will include aspects of the culture and they will test it for use in this group specifically, which is also a very popular movement right now. So on one hand, we have things like the unified protocol that are trying to widen the lens and say, you know, this is a therapy that's developed to try to work for a bigger variety of people because it's looking at the common elements. And then we have culturally adapted treatments that really focus in on how do we kind of handcraft this treatment for this particular group. There are also issues in bridging the gap between research and practice. So efficacy study results are not always heeded by practitioners in the real world. So it's pretty common for therapists in the community to just kind of practice how they practice and not necessarily stay current with the new research that's coming out. And there's several factors that kind of affect the reluctance of practitioners to kind of focus on evidence-based practice. So some practitioners place a higher value on their own intuition and judgments, which we've talked about. Kind of the analogy of a surgeon is not necessarily what you want when you're going to see somebody who's a medical professional. And a lot of times research can be seen as irrelevant to day-to-day practice. So part of this is kind of the flaw of the academic system, is the way that we're writing up research studies is not necessarily accessible for people who are working as community practitioners. And it's really important to help bridge this gap. And so there is a big effort to disseminate treatments that are affected by this gap and to really educate practitioners in the community about the importance of delivering evidence-based practice. One solution for this is to do more practice-oriented research. And this is a strategy that aims to increase the collaboration between researchers and practitioners from the very beginning. So from the point of an efficacy study, it's already including community practitioners. And so we can develop what's called a practice research network, which is like a group of therapists and researchers who are working together in all phases of a research study, with the ultimate goal that dissemination of that psychotherapy will be much smoother and will be much more kind of true to its original intention if the practitioners are involved from the very beginning.